we're going to do now is move on, and I'm going to hand over to Jane Burt, who's been monitoring all the questions, and we'll open it up for the next 20 minutes on some of the questions that have come through for all the panel. So if the people who've been speaking, be prepared, you may be pounced on by Jane.
For you. Hi folks, yeah, really excellent presentations today. I've got some questions here. I've got a few of my own if I've got time to ask them, but please do post any if you can think of them. I'll stay with our colleagues at GamCare for the moment. One point here made by Ellen, which I was actually going to bring up. So she says, great presentations, very powerful. I'd like to access the training at GamCare and link it in with our Op Courage services. I'll be in touch. That was something that was occurring to me. Is there work going on to link up, you know, an organisation like yourselves with the Veterans Mental Health Services? Or is that very much based on people taking on that initiative locally? Do we know about that, Gracie or Annette?
Yeah, that's very much around, obviously, local contacts. There are training and engagement leads all over the country. As Gracie said, you know, we're based and covering London and the South East. We would be more than happy to take any details of anybody all over the country, and then obviously pass those details on to our colleagues in the specific areas, which will have a lot more local knowledge. But yeah, we're very, very keen. Gracie and I am really passionate about this subject with women in gambling, because we can see the huge increase, the numbers of calls to our helpline, etc., and the impact that it's happening. So please do reach out to us and let us give you that training session and that information so that you feel confident to be able to identify any issues, or just to have that conversation with individuals within your services. But yeah, just because we're covering the London and South East, don't worry, we can pass your details on to our colleagues within the programme.
Brilliant, thank you. I just wondered if Nikki wanted to come in here, because you mentioned gambling earlier, and obviously your PPV group, Nikki.
Yeah, I was so pleased to see this presentation today, and I don't know if Ellen is still here, but I know she's going to get in contact to talk to both of you about how we could link into the training. I had a question myself, if I may. Clearly you've got the regions in England. What does GamCare or a similar organisation do in the other home nations? Because one of the health inequalities for the UK Armed Forces community is the UK bit of it, and the fact that everything is delivered differently in the 4 home nations.
GamCare do cover Scotland and Wales as well, and we do have we actually don't have any women's programme training and engagement leads in Northern Ireland, but Gracie, I believe we do have a young person's programme that runs out of Northern Ireland. Is that correct? And we provide support there.
Yes, we do. We do have a young person's program, and we do what we do. GamCare we don't have directly delivered service all over the UK, but we do work in partnership with other organisations that deliver services on our behalf. So we've got Beacon up north as well. Break Even as well does some of our services down south, but they all work across the same care plan, and everything is uniform the same. So it might not be GamCare directly delivered, but it will be the same kind of treatment that would be available.
I mean, that would be really, really useful, and I am very happy. We produce a monthly briefing for the armed forces community for registered stakeholders, and that gets out to quite a wide community. So if you've got something that captures that information, I'd happily get the Armed Forces Comms and Engagement team to include that in the briefing, and likewise for any of the other presenters today. We clearly covered it with Lauren's research and with Paula's, but that briefing goes out to the Armed Forces community and any other registered stakeholders who have an interest. So if you want to send that to me and or Ellen, then please do. And in terms of the PPV group, one of the things that I learnt, which is why it's sort of high up on my agenda, is that on operational tours, when people were not deployed and they were sitting in their forward operating bases doing absolutely nothing, bored, rigid, that's when the gambling started for some of the guys. And I've got guys on the PPV group who are recovering, and I had no concept that that's the sort of place that gambling can start with, you know, matchsticks and that sort of thing, and then it progresses and progresses. And so for me, the whole issue of addiction is substance abuse and gambling, and I don't think it's spoken about enough.
You're absolutely right, Nikki. And I think that's why we see such a massive problem in prisons as well. A lot of people in prisons will say it's the boredom that drove them to start gambling. And we really do underestimate how severe that addiction can become and the impacts of that addiction. Before my role here as well, I used to work for a rape crisis, working with women who'd experienced sexual violence. And not once in our assessment forms did we ever look at gambling addiction. And it was only after that I realized, oh my God, a lot of the women that I was supporting were using gambling as a coping mechanism. And I didn't realize it. So it is really important that we're raising that awareness and we're having those conversations.
Yeah,
and I do wonder, sorry, how many military spouses who are left alone for long operational tours and deployments find themselves in exactly the same position. And there's no research on that, I suspect.
No.
Not that we're aware of. I mean, gambling addiction is so far behind substance addictions and things like that in research and awareness, which is obviously why we do the roles that we do, driving that awareness as much as possible. And in the full training, we actually show a video, and we were umming and ahhing about showing it today, but we were a bit short for time, around gambling in the brain. And it really helps you understand, because often people will just say, well, they've run out of money, why don't they stop? It's not as easy as that. It is so addictive, and it is so addictive so quickly, you know, and the algorithms are set up, the programs are set up to keep you enticed. And it is so very important that we're aware of it and how impactful this addiction is. And you're absolutely right. You know, you've got people sitting on their own, if they're a bit bored, something for themselves, you know, something that they can do, then they think, you know, they get a bit of a reward from it. And what can be perceived as something that's quite innocent to a certain degree, because we accept it in society. It's advertised everywhere. We all think about different raffles, for instance, different gambling activities, but actually it is so massively impactful when it becomes to that problematic stage.
Thank you. Yeah, question there from Sue, still saying with the gambling. I don't know if you can answer this. So saying, due to COVID, have we seen an increase in people's gambling habits? She's talking specifically about armed forces community. So I don't know if you can answer that, or I mean, just generally, have we seen that as an issue?
We've seen it generally. That's something, I think in the first lockdown, our helplines went really quiet and we were a bit worried. And towards the end of the first lockdown, we had a sudden influx of people. We had to recruit a lot of other staff onto our helpline because we couldn't deal with the amount of calls that were coming through. But a lot of people really did slip back into that problematic gambling phase. A lot of people who had already been in recovery for a number of months or even years, unfortunately, during that lockdown, that first lockdown, which was really tough for a lot of us, really fell back into that problematic stage on the continuum. So we did see a massive increase during COVID, and I saw Sue wrote about people being at home a lot, and I think that was a massive trigger for a lot of people being in their homes. And one of the things the government did in the first lockdown and in the second lockdown was ban them from doing any adverts on TV during daytime, because they started to notice the impact of the advertisement on people who were stuck at home, probably financially in a bad place, and thinking, hold on a minute, I'm bored, number one, and number two, this could be a way to solve my finances. So it was a really big incentive for people to partake in gambling. So the government did put a hold on those adverts going out during daytime, but once we came out of lockdown, that went straight back on TV. So we did see a massive increase during COVID.
Thank you. I'm going to move on now. A couple of questions here for some of our other panelists. Michael, thank you for your question. For Paula, so saying that you were surprised to hear that most physical assaults on female service women were by other females. Do we understand any of the factors that contribute to this? Any thoughts on that, Paula?
Hi. I'm trying to be diplomatic about it, so I'm pausing for a second to try and think of the right words, because I'm used to speaking extremely frankly. So for a lot of women, a lot of the women who joined the military, they felt like there was two social groups that they could be part of. One was based on sexuality, and the other was based on, I guess, having different sexual relationships with men. And for a lot of the women who didn't feel like they fitted into one of those groups, they felt like they were victimized because of that. So they felt like if they didn't fit into a social category or a cohort or a group, that they weren't allowed to be part of anything. So they were completely isolated from the unit. And a lot of them talked about women turning against them because of that. And some of the women, only a handful of the women, talked about when they had went to a senior officer who was a woman to report abuse of some nature, that those women officers turned against them and made the life a living hell and physically attacked them. So I think there's lots of different reasons why that occurred. And we're actually going to be releasing soon some LGBTQ plus research where we interviewed just women, and that goes into those dynamics a little bit more.
Great, thank you, Paula. I'll come to a question that probably a few of you can have some advice about in a moment, but Lauren, can I just ask you, when you spoke about your research, you said that female veterans were less likely to access a veterans mental health service. My question is, does that mean women are missing out on mental health support generally, or they're more likely to go to a different mental health service? What does that mean?
So there's inconsistent evidence, I would say, in regards to this. So in terms of the veteran-specific mental health services, we really don't have a lot of data on that at the moment. There is some internal data that I've been shown before that suggests that there are lower numbers or lower proportions of women accessing the Op Courage type services than you would expect, considering they're already a minority. It was only a small study. It was a pilot survey that looked at differences between men and women's access to different mental health services and also barriers to care and things like that, which suggested that women were significantly more likely to be accessing the non-veteran specific mental health services. So it's not necessarily that they're missing out on accessing services, but they don't seem to be accessing the veteran specific services. And as I say, this is all kind of preliminary emerging evidence, but also within our research, our stakeholders, our subject matter experts all spoke of issues that anecdotally they'd come across with women not feeling comfortable accessing those services. So some of the things that Paula has talked about in potentially feeling re-traumatized by that male-dominated, or a perception of a male-dominated service, or that it might reflect the military culture again. So there's a lot to unpick, but it does seem like that potentially these veteran specific services, for whatever reason, are either not attracting or targeting women or are not meeting their needs in some way.
Thank you. And I see Ellen's let us know there that 8% is the figure for women accessing Op Courage. So thank you for that, Ellen. A question here, maybe for several of you, all of you.
Jane, sorry, could I just say that I think one of the issues, and it's come up in the research, and hugely pleased to see so many people saying in the chat that they're women veterans on here. Yeah. But I think the issue of women not identifying themselves as veterans is part of that issue, and I think, and Ellen will want to come in, no doubt, after I said this, but that allied to a preparedness of women to seek help from NHS mainline services, as opposed to services that, you know, Op Courage has only been around since 2016. So those sort of conspire together, I suspect, to make the numbers lower than they actually are, which is why, you know, it's so important to identify yourself as somebody who has served and spread that word, because it is, I suspect it's an awareness issue, as well as some of the issues that Paul has talked about and Lawrence research has discovered, but it's relatively new and allied to that need to feel that you can identify, even if you don't call yourself a female veteran, but somebody who has served will help. And when we can get the identification of veterans to a more refined state across the piece, then I think that will help too.
Can I also just talk about my experience with that, because I do ask women this question because it's really important to understand why women don't access services. And I do a lot of work about dispelling myths as well, and talking about how to access services. And a lot of the women that I talk to who do need mental health input talk about when they think their perception is that if they go to Up Courage, that the clinician is going to be a veteran or somebody who has served, and they don't want to see somebody who has served in the military. They want to see somebody who's completely separate. So I do a lot of work with women understanding that actually that isn't always the case, that you do have choice. If you just be open and honest and say, I would prefer prefer a civilian or someone who served in the military, then Up Courage will accommodate that. So I do talk to a lot of the women about that.
Thank you. Sue makes another great point here. She was a triage nurse for combat stress, only occasionally get calls from females. Maybe part of this is due to being few female pictures, etc. Actually, when I think of combat stress, I think of their advertising is mainly men that I've seen in that. Correct me if I'm wrong. But yeah, you know, absolutely. And this next question, well, this from Claudine, this actually goes back to what you were saying. I'm thinking about what employers can do for women. I was really quite shocked to hear some of the things you said about some sort those basic needs of women, like sanitary products, contraceptive and so on. You know, only recently that becoming something that women are offered in as part of their job in the armed forces. I was quite shocked by that. The hair as well, sort of basic things that we take for granted on City Street, maybe.
Yes, with that, yes. So that only, so the hair was only probably about a month now that came out. The the sanitary stuff also was only recently a week. So what I was saying previously, they have evolved compared to what it was before. It's taken them a long time. They are getting better in terms of that. Still not 100% there that I mentioned, but it's a lot better than what it was there. And a lot of people wouldn't know these things, wouldn't, if you're not in the military, wouldn't understand these kind of things, especially with the accessing contraception on deployment and all of that. Yeah, still an issue there.
And can I, Claudine, I don't know if, forgive me if I missed it in your presentation, did you say there is like a Women in Defence network?
Yes, so there's a Army Service Women's Network. So I think each service has got their own network. The Army has theirs, a Service Women Network. They've also got the Breastfeeding Network. They've got the Army Parent Network. So there are a lot of different networks that are coming out now.
Fantastic, thank you. So question for all of our speakers, really. So a colleague here who's working for Medway Council and said that they're a member of the Employer Recognition Scheme. Should we be doing more around sort of gender specific support? How long have we got to discuss that? But you know, that really, that was my thinking through the whole day, really. What some of the things we need to be considering if we're not providing specific services? What more can we be doing? Number one, identifying female veterans, of course, is at the top. Asking the questions, not assuming we know who veterans are. Any other ideas from any of our panelists or our guests? Andy, you've got your hand up actually.
Yeah, thank you,
Andy
Jane.
B.
Yeah, hi everyone. Andy Bington, Kent Fire Rescue Service. I am one of our service and welfare support officers, and obviously we've got many pathways into mental health services, support networks, etc. Obviously, the Armed Forces Network Champion is one of them, but obviously we do have employee assist program, which is anonymous. So we're, as welfare support officers, we are pushing. If you don't want to let us know as an employer what your issues are, you can go to the EAP, albeit for us then to get a report back, we will send people to We Are With You. But for those people that don't want to let us know or have got stigmas around mental health issues or actually accessing support, we can push them through the EAP. So because we get statistics about what the issues were, but not the actual individual. So
yeah.
it's a really good
it's
point.
Anonymously fed back.
Yeah,
Brilliant.
so if you can highlight that to employees, it's supportive.
Brilliant. Thank you,
you.
Andy. Nikki.
Yeah, I think one of the things, and this applies to any minority group really, and I say this to Ellen in the course of our discussions, is that when you've got a minority that is not necessarily deliberately made to be a minority, but it just seems to be a fact. If you sort of have what I would describe from my military service as a mandatory paragraph heading. So when we're talking about, commissioning a service, to make sure that everybody thinks about patients first, if patients is a mandatory paragraph in a contract or in a paper that is seeking money or seeking to commission a new service, if everybody inserted the things that we know should underpin every aspect of new service development that we're including, so if for the Ministry of Defence they always had a paragraph on Commonwealth soldiers, on females, it would just make people think a bit more about it, because a lot of this is not about intent, it's about or bad intent, it's about years of practice where things have evolved, and as Claudine has said, loads of stuff has changed since I was serving, and really good, and quite right that it has. It's a damn shame, excuse my French, that it's taken until 2021 to be talking about sanitary products, hair braids and contraception. I mean, that's the galling thing if one is honest, but it's getting there, it is improving, and what we've got to do is get people to think all the time about the minorities, and make sure that it's built into what we do, if only to serve as a reminder, rather than create feelings that we're all being hard done to, because actually that isn't the case. We just want it to get better. And, Paula is at the sharp end of seeing stuff that isn't better, and it needs to be improved. And those are the bits in the healthcare space that certainly the Armed Forces team are looking at. But I think this applies to any minority group across the NHS and social care and the public sector per se. Sorry, I've got off my soapbox now.
No, that's absolutely brilliant. Any other comments from our panelists or audience? Okay, well, folks, we're coming to the end. We're just going to have a quick presentation of some awards we had. I'd just like to say I think this has been so positive. I've taken lots away, lots of you networking and planning to meet up in the chat. That is just fantastic. So let's keep on with that.